Hello, everyone. This is Kathy Bush, and welcome to the DandleLION Medical Webinar from Preemie to Young Adult, a 26-year retrospective look at parenting a NICU graduate. We're so pleased to have Laura Miller with us today as our faculty presenter. Laura is a healthcare consultant, writer, and educator. She is the managing consultant for the March of Dimes Foundation, overseeing the NICU Professional Development Program and bringing evidence-based family-centered education to perinatal staff nationwide. She specializes in effective communication between providers and families, supporting families in crisis, improving the patient experience, and solving challenges associated with a multi-generational workforce. Laura is also Principal Advisor of Patient and Family Engagement for the Ohio Perinatal Quality Collaborative, working with families transitioning to home with a trach or G-tube. Laura and her family live in Kansas City, Missouri. And Laura, we're thrilled to have you with us today.
Thanks so much. I'm super happy to be here, Kathy, and just really happy to share my story with your audience today. So I'm just going to get right to it. I wanted just to take a moment and look at this baby here and the t-shirt, and that NICU graduate now what sort of sums up what discharge day looked like for us. So today, that's kind of what we're going to be talking about. What happens after the NICU? So for the next 45 minutes or so, we're going to be talking about these three things. We'll look at the long-term effects on parents of a NICU stay. We'll talk about how minor morbidities or co-morbidities don't seem so minor to NICU graduates or to their parents. And we'll also be looking at strategies to support NICU families during and following their NICU stay or their hospital stay. So Kathy shared my bio at the opening, and I just wanted to give you a little bit broader glimpse about what I'm doing right now and what brought me to this point, and probably more important, what I was doing 26 years ago that sort of led me to there. So I, similar to what Kathy just mentioned, I'm also a certified patient experience professional through the Patient Experience Institute. I am passionate about education in general. You'll see on the next slide how it really has been a thread through my entire life. But for the last 13 or so years, perinatal and NICU professional development has been sort of my wheelhouse. You're going to hear me talk a lot about my two kids. They are young adults now, and I have been married for over 30 years to Kelly. So no comments in the chat box, please, about my hair or the denim jumper. I'm slightly mortified that I'm even showing this picture on here. But who I was back 26 years ago was this person. I was younger. Had been only married for 5 years. I was an elementary music teacher. That's what I thought I was going to be doing my entire life. And as most of you in the NICU know, life happens to parents. And for me, life happened by having twins who were in the NICU, and it changed me. It changed my personality, and it changed the course of my career as well. I want to just spend a little bit of time also talking about pre-existing crisis experiences, because many times our families in the NICU, we discover too late that not only are they dealing with their acute crisis situation right at hand, but they're also bringing with them sort of that crisis background. Whatever has happened in their past, they're bringing that with them as well. And sometimes we have to deal with that also. So my personal pre-existing crisis experience was that my brother, who was 2 years older than me, died unexpectedly 2 years before my twins were born. And it really wasn't until our NICU experience that I realized that I had not properly dealt with his death. I hadn't processed it right. I had instead just sort of pushed it all down and hoped that it would sort of never come back again. But clearly, all of those unresolved feelings and sadness really did enter into the mix of the whole jumble of trying to also then cope with what our experiences were going through with our boys. So as healthcare professionals, we really need to be flexible and prepared with those hidden traumas that are sometimes unexpected. But we really should expect them. We know that everybody brings life experiences to this situation. So Ian Benjamin Miller and Alexander Nathan Miller were born 2 days before Mother's Day, 26 years ago. They were born 3 months early, and I delivered in a birthing hospital very close to my house, and they were immediately transported to the Children's Hospital, which was about 30 minutes away. I spent about 4 days. Actually, that's kind of fuzzy. That experience is a little fuzzy, but I think I spent 4 days on the maternity ward without my boys. I could hear happy congratulations in the rooms next to me, and I was watching through my open door excited families pass by with balloons and with gifts. And the maternity ward is a terrible place to be when you're a mother and your babies aren't with you. They're not in the room with you, or they're not even at the same location with you. I really wish that my hospital had made some preemptive arrangements for mothers like me. I know I wasn't the first mother in this situation. I know I wasn't the last mother at this hospital in that situation. So it's something to think about if you are in a birthing hospital and you have mothers who are delivering preterm or unexpectedly. Think about where they're at and what the impact might be. During those couple of first days, my husband Kelly was putting hundreds of miles on his car that week, going from me to the boys and then back home to let the dog out. Our dog's life changed drastically as well during that time. But Kelly was really amazing, always bringing me the latest update from the hospital. He was bringing me the Polaroid pictures. I'm sure if you've been practicing long enough, you remember Polaroid pictures. Those early days, that's really all I had. So for the next few slides, I'm going to be showing photographs, personal pictures of Alex and of Ian and of our family. And these are pictures that I've never shown before in a large audience. And in fact, I'm not even sure if my own family has seen all of these photographs. And so I ask that you just respect our privacy and please don't take any screenshots of these photos. I would appreciate that. So I look at this heading, First Days, Terror and Trauma, and it seems maybe a little melodramatic to state it that way. But when I look back in the journal that I was keeping during those days, I kept a journal, I wrote every single day in it, and those words are loud and clear in the first few pages. Terrifying, terrible, terror, trauma, traumatic. So it's really not melodramatic. It really was what we were going through during those first few days. For Kelly and I, there was this overwhelming, looming sensation that we were completely out of control and we were just sort of along for the ride, and we didn't necessarily want to take that ride. So those were definitely scary days. So you can see that Ian was baby A. He was born first. He was 2 pounds 4 ounces, and his length of stay was 93 days, or right at 3 months. And Alex was more sick. He was more little, and his length of stay was exactly double, 186 days, just over 6 months length of stay in the NICU. So here's Kelly on the left reading Cat in the Hat to Ian, and there he is, just being nearby for Alex and touching, not holding yet, but just touching and being able to be present in the hospital. He's in his work clothes, I can tell, because he's wearing a tie, so I know that he had come just straight from his office, and that's what a lot of our dads are doing. They're coming, they're working, they're keeping the job, keeping the house payment paid, they're keeping the insurance up, and they're staying strong for their family. So as you can imagine, 6 months in the NICU included both good and bad days, and that meant we had both good and bad memories of those experiences. Surgery days for us, definitely, and the days leading up to surgery days were bad days for us. They just were. You can see on the left, Alex developed a hernia very early on. It was an inguinal hernia, and it was so large that our neonatologist and the NICU team weren't exactly sure what to do. In fact, our neonatologist said to us he had never seen a hernia that large on a baby that small, and asked our permission, asked us to sign consent forms to take pictures of that and send it off to his colleagues to NICUs all across the country, just to get a better idea of what they should do. They didn't want to do a repair. They were worried if they did a repair on that with such a little guy that it could lead to further complications. And so they waited, and we waited until it actually did become an emergent situation, which happened when he was 5 weeks old. Excuse me. So on the bottom right-hand side, you can see, as anticipated, that hernia surgery really did lead to further complications for Alex, and he ended up needing a trach and a vent a couple of months later. And for Kelly and I, a tracheostomy was sort of the ultimate terror technology for us. The proposition of bringing home this very fragile baby on oxygen with complicated and technical equipment was way beyond anything that we had ever bargained for. And even with the trach education that we received, we were just very nervous about bringing Alex home. On the top right, you can see that Ian had a grade 3 brain bleed. It resulted in hydrocephalus for him, and then when the lumbar punctures or the spinal taps didn't do what they needed to do, didn't resolve it for him, he ended up with a VP shunt and then a shunt revision 3 weeks later. This picture in particular, but really all three of these pictures, sort of illustrate for me the shock of post-surgery, post-op. We were both completely unprepared for what Ian was going to look like coming out of the operating room for his the first shunt surgery. I really wish that the surgeon had given us more preparation for what it was going to look like. It would have been very helpful for us to have had pictures of what a baby looks like coming out of surgery. They're so much swollen. They're bruised and battered. They're bandaged. You know, our surgeon said there will be a small incision on the back of his scalp. There will be a little lump there. He'll have a small incision on his neck, a small incision on his abdomen. But we just weren't ready for what it looked like. So that missing piece of anticipatory guidance would have been better for us. And I urge you to go back and think about how you prepare families for surgery, not just for the clinical outcomes, what you expect the surgery to repair or to fix, but what it's going to look like when the baby comes out, and how long it's going to take for that to sort of, the swelling to go down and to look better. So our best days and our best memories really do sort of revolve around holding our boys, being able to be parents. So this quote, "Today I feel like a parent for the first time," was something that I wrote in my journal on the day that I held Ian for the very first time. He was, as I mentioned earlier, he was the least sick of the two, and so we were able to hold him first. And you can see on this picture, I was, Kelly's looking over me, and it felt so great to finally get one of our boys in our arms. The sad part about this story or this quote is that the first time that we held Ian, he was 5 weeks old. And Alex, it was 2 weeks later. Knowing what I know now with 27 weekers, there's no reason why we couldn't have held sooner. What I didn't write in my journal was, if I felt like a parent for the very first time at 5 weeks, what did I feel like during those 5 weeks prior to that? What was I? Where was my bonding and attachment? Where were my maternal instincts that hadn't kicked in yet? And why was it that moment that I held him for the first time, I felt like a parent? So if you learn nothing else from me today, it is to get that holding with the parent and the baby connected as early and as often as you possibly can. Back in 1991, my hospital was not offering skin-to-skin care, although it was happening in other hospitals around the country. But we know for sure that there are proven benefits, not only for the baby, but also for parents who are holding their babies skin-to-skin. The March of Dimes Foundation developed an entire program around skin-to-skin holding, and it's called the Close to Me program. It includes parent education, staff education, materials, booklets, flyers. So if you'd like more information on that, just send me an email at the end of this. I'm happy to share that information. And we also do staff trainings, we do webinars. So I know we have a number of people from around the globe who are on this webinar today. If you'd like to have a webinar, I'd be happy to hook you up with the right person. We had limited bonding opportunities for us, but again, they really did revolve around just cares, around parenting. So our first family hold was this picture. They were 9 weeks old. It took over 2 months for us to actually get chairs side by side and our babies side by side together. But again, ignore the hair, bad perm. But you know, by looking at our faces, we're happy and comfortable, and it just felt great to be able to have that opportunity. Again, it should not have taken that long. One of the reasons why it did, and part of the bonding opportunities for us, was that at 9 weeks old, we actually got to have our boys together in the same room. In our NICU, it had 3 separate rooms in that NICU, and the hospital policy at that time had their policy was to keep all twins separate as a way of eliminating mistakes. They were afraid of giving the wrong dose of medicine to the wrong kid, and so it took over 2 months for them finally to get to the same room. But being able to sit in the middle of those 2 beds and look to the right and to the left and see my boys had this really terrific, calming sort of experience and feeling for me. So again, just look at your policies, go back and how do you work with twins as far as when one is discharged, one comes back, you know, what are your twin policies and family-centered care policies? When we entered the NICU on May 10th, for me, time really sort of stood still. I stopped turning my calendar on my refrigerator at home over. I didn't have time to watch the news. I didn't listen to the radio. So I had completely isolated myself from our friends. We had a very small group of family that we sort of let into that circle, but for the most part, our world just sort of stopped. Now my husband continued working, and so his world was continuing on that way, but really we weren't involved in any activities. We just stopped doing everything that we had prior had been doing. And you can just sort of see those bubbles that we spent a lot of holidays, a lot of time during that 6 months that we were in the NICU. At the bottom it says the school year started. I didn't go back to school that year. Clearly I was able to stay home. Which, lucky for me, I was able to do that. So Alex then came home in early November, so they were there all the way through Halloween. It would have been really great if the NICU had provided us with some kind of activities or events or education just to help us mark time. I think it was a missed opportunity. So again, think about what you have planned for your families during the length of stay. We are a captive audience in your unit, and you really have a lot of power and opportunity to make it the best possible opportunities for us to learn. The March of Dimes NICU Family Support Program partners with over 130 hospitals nationwide, and they offer an amazing curriculum of parent education and written materials, books and events and activities. A lot of them right now are right in the middle of Kangaroo-a-thon events. They do holiday meals and just opportunities to meet other parents. All of those things would have been an amazing gift to both Kelly and to I. And I just think that that's one of the things that would have helped me later on. I'll talk a little bit about some of my own sadness that I had and traumatic experiences afterwards, that I really I believe wholeheartedly that if we had had a program like that in our hospital, that would have helped some of those issues that I faced later on. So I want to say a few words about the importance of communication. So much information is conveyed that centers solely on the clinical needs and the progress of the baby, which of course, very important. Parents need that information. But sometimes what gets overlooked is the need to connect with parents on a deeper and more personal level. If you can just make time to do that, sitting with a family and just getting a little bit closer and connecting with them a little bit more beyond just the clinical piece. I think that that would be helpful also. There's some great articles out there on how you can communicate good with families or better with families. But this is a brand new article. It was just released last month in the Patient Experience Journal, focusing on the simple act of sitting and just talking with a parent. So this hospital started their Commit to Sit initiative, and they saw their patient experience scores increase. And it really is such a simple thing to do. They gave their nurses, and this isn't just the NICU, this was hospital-wide, they gave their all of their staff scripting. As simple as this: do you mind if I come and sit and talk with you? And just to get the ball rolling. So sometimes we're a little bit nervous about, well, what do I say? I'm not sure how far I should go into a conversation. Don't want to cross any boundaries, but having that communication is, it shows that their patient experience scores, parent satisfaction is better. So this idea, of communication goes really beyond this "hi, how are you" question, and it dives deeper. This question, "how are you," was always kind of good for me because I really didn't want to go deep. I just wanted to say fine, and that was it. I didn't want to tell them that I was sad and isolated and confused and broken and, felt like I wanted to get into my car and drive and just keep driving and never come back. For me, I felt really guilty about those thoughts that were sort of twirling around in my head. So I think that questioning, if you're consistent with it, can I just sit and talk with you for a while, can be helpful. Some other words or phrasing that you can use, it's that first one, do you mind if I sit and talk with you? But one of the phrases that I used a lot when I worked in the NICU years later, when I was talking with families, I would just say, tell me what's going on in your world today. And that leaves it up to a really large interpretation. So they can tell me about their drive into the hospital that day, or their bus ride into the hospital today and some missed connections, or they might talk about their third grade child who had an award ceremony. So there's a lot that that question sort of leaves it open to. I really encourage you to dive a little bit deeper into those connective questions. So yay, transition day finally happened for us, and I kind of laugh at this because we really didn't know what we didn't know. When you look at this car seat safety, this picture on the left, this is Ian. We strapped him in. This was his discharge day, and I took the picture in the hospital parking lot. And you probably right off the bat can see a lot of things that are wrong, but there's just a few of them. It was a 3-point harness, not a 5. We didn't know. He was all bundled up. We didn't know that his legs should be separated. His straps are all messed up. And then when this was Alex's first day home, so this was 6 months later, or 3 months later. And they're co-bedding. We don't know anything about safe sleep. There is all sorts of wrong in this picture. I will not go into it. You all know what it is. But those are sort of some of the conversations you can also be having with families. Just sitting with them and saying, "Tell me what the room is going to look like when your babies come home. What does your bed look like? What does the baby's crib look like? What do you have in it?" So really start those conversations with them and get. A lot of times our families have sort of a deer in headlights look, and they haven't even thought about what a crib might look like or how the room would be set up. So those conversations as you're getting close to discharge day is great. So I saw on our registration list for today's webinar that some of the attendees are from home health care agencies and also equipment companies. That makes me so happy. We went through several rounds of home health care nurses before we were able to find the right mix. We actually did find some amazing women who were able to be in our house and care for our boys. But we learned very quickly that we had to advocate for ourselves. We had we had several nurses who came to us who had no tracheostomy background at all, expecting us to train them, to teach them what an emergency looks like and how to change a trach in an emergency. We fired them on the spot. And that's a horrible position for a young 25-year-old mom to be in. And so, you know, if you're a home health care agency director, I know you're in a tight spot. This diagram kind of talks about some of the challenges that that hospitals face when you've got chronic kids going home with a trach or a G-tube or needing home health care. So the orange dot is where the hospital is located. And for the United States, a lot of the hospitals, children's hospitals, where the kids who are being discharged to home with a trach or a G-tube or other medically complex conditions are usually right in the middle of the city. So they're in the inner city. And just beyond that then is the urban core. About 20 miles out is a radius is the suburbs. And then you've got the rural areas much farther extended out beyond that. We were lucky because we lived in the blue ring. We lived in the world of suburbia. It was very easy for the nursing agencies to staff our house for the amount of time that we needed nursing, and we really never had any trouble getting a nurse come to our house. But for the families who aren't as lucky or who live in other areas, they live in the urban inner city, the urban core, or they live, you know, in our rural areas of the states and in farmland. It's really difficult to staff and to get that scheduled, you know, that the scheduling of home health care nursing in a house. So it was a problem in 1991. I know it's still a problem today, and something that we need to work together to fix for sure. So this is just a photo credit off of Pinterest. I was looking in my own photographs and realized I don't have a single picture of what the bedroom looked like, our nursery looked like with the boys, but just picture this double. So we had 2 cribs, we had 2 stacked shelving, we had a ton of oxygen tanks, 2 monitors, two of everything. And it was like an ICU, a residential ICU. So again, it would have been very helpful if somebody had even given me an idea of how to set this up. Right now, you know, on social media, Pinterest is a great resource, and you can sit at the bedside with a family getting ready to go home that are going to have chronically medical complications. Sit at the bedside with them, pull up Pinterest, and just search under NICU and tracheostomy and home, and you'll be able to find a lot of pictures that you can talk through some of these things with your parents. That kind of, again, anticipatory guidance would have been super helpful rather than just having to try to constantly reinvent the wheel. So our boys were home at 6 months, but Alex continued to have some major challenges. He was readmitted back to the hospital, to the PICU. The policy of the hospital was that he couldn't go back to the NICU in those days, which was horrible for us because we loved our NICU staff. But he was readmitted back to the PICU 5 times in the next 2.5 months. And when Alex was just 9 months old, just less than 9 months old, he passed away. And this is our last family photo that we have of him, of all of us together. And for those of you who wonder about what is the best way to support and to comfort a family through a loss without crossing boundaries, we've really had some amazing, incredible examples of empathy and staff who cared and really loved us. It is okay to cry with a family who is grieving. I've been asked that before. Was that awkward if a nurse or a doctor shed a tear? And we just appreciated knowing that our loss was also your loss. We had a team of nurses and doctors and even one of our surgeons who attended Alex's funeral, and they came as a group supporting each other as well as supporting us and showing us their love. So so you can show emotion, and it felt wonderful just to be able to know that you cared as much as we cared. So after a lot of discussion and and talking about whether or not we ever wanted to encounter a NICU experience again, we decided to go ahead and get pregnant again. And so about 18 months later, or about 2 years later, Isabel was born, and she had no complications, and it was a great experience. Just a quick side note about Isabel: she is getting her master's degree in occupational therapy at the University of Kansas Medical Center, and she wants to be an OT in the NICU. Makes me very happy. So again, I know that on the registration list, I saw that some of you are working in the either developmental preschools or OB office, the pediatrician's office, follow-up clinics. So I wanted to talk just a little bit about our experiences as he was developing. So just a quick note about growth charts. Again, this is not Ian's growth chart. I pulled this off of the internet, but clearly that bold line is sort of where the median or the normal range is. You've got the highs and the lows, and then those little red dots are where your baby falls as far as height and weight. And so Ian's little red dots were much lower than this. And every single time that we went to the pediatrician's office, they weighed him, they measured him, and I always got this chart with his little red dots way below where they were supposed to be. And after a while, I just finally said to the nurse, "Do not ever show me this chart ever again. It makes me feel bad, and I already feel guilty about everything. So just keep it to yourself and don't show me. I know that he's developmentally delayed. He was 3 months premature." So again, think about what you the materials that you give to family and what the potential impact would be. This wasn't malicious in any way. She just wanted to inform me. But think about the impact of some of the things that we hand to parents. Ian had this incredible infant developmental preschool. It was amazing. It really helped him progress, and it was sort of a godsend for me as well. I was able to attend and to be a part of a lot of those therapies, and so that started helping me heal through some of the experiences that we went through. One day, Ian was doing physical therapy at his preschool, and the physical therapist and I were both on the floor, and we were tossing a ball, and Ian would run away from us, grab the ball, and bring the ball back to us. And I said to her, she was a pretty new graduate, she was great and very excited and passionate about her work, but I said to her, every time Ian runs away from us, he's on his tiptoes, and I've never seen a kid on his toes that often before, so I wonder what's up with that. And she said, "Oh, well, that's his CP." And I said, what is CP? I don't know what that is. And she told me that Ian had cerebral palsy. It was the first time I had ever heard that before, and I was shocked. I was devastated, and I had this immediate image that Ian was going to spend the rest of his life in a wheelchair without the use of his hands or his legs, without verbal or good cognition, and I was honestly horrified. And so I know that there are a number of OTs and PTs on this call today, and so I just urge you to think about, you see this all the time. You recognize when a child has a condition that needs to be diagnosed. So just a simple phone call from her to my pediatrician to say, "Hey, look, I just need you to know that I'm seeing something. I think you need to give a diagnosis pretty quickly so that we can start working with that." I actually walked out that day from physical therapy with nothing. I walked out with no brochure or handout or information on what CP was, and I was just sort of left with my own ideas of what life was going to look like for him, and that was a bad day. So don't be that person. We also made a number of trips, a lot of trips to the emergency room, and most of them resulted around the swelling around his shunt. The surgeon really did sort of strike the fear of God in us with to be on the lookout for swelling of the shunt or if there's fluid around it. So I sort of became obsessive and compulsive about touching the back of his head, just to know where his baseline was and then to know if it was getting bigger. A number of times it would swell up, and we'd go in, and every time I sort of wondered, is it right? Am I doing the right thing? Am I being overprotective? Do I trust my gut? Does the provider see the same thing that I'm seeing? And really only a couple of times did the staff and the ER sort of make us feel stupid for coming. Usually not. Usually they were really good about just confirming that we were okay, we were doing a good job. And a couple of times we actually needed to be there in the first place. So that's always a hard thing, though, for parents. They're never sure if what they're doing is right. Follow it as a follow-up once they're at home by themselves. I've had the opportunity to interview hundreds of NICU parents, and there's a common theme of parents with children with chronic conditions. The first common theme is this: they're almost all in crisis, some kind of crisis. They're also mostly all suffering grief and loss. Whether they've lost a baby or not, they've lost the idea of what they wanted as far as their pregnancy. We're also all navigating new systems. Each unit in the hospital is its own system. So even though we spent so much time in the NICU and then would come back to the PICU, that's a whole nother system. It's new staff, it's new terminology. We don't know where the bathrooms are. There's a whole lot that changes. But then once you get discharged, all of these other things are systems that are very difficult to navigate, and they don't communicate very well together. I wish that there was a better way that could happen from the NICU or the PICU discharging to the pediatrician or to the follow-up clinic. Just one little shout out about Medicaid and waivers and waiting lists. I don't think I've got waiting lists on there, but there are a lot of waiting lists if you're dealing with Medicaid. Those applications are really difficult to fill out, and more than just as a social worker saying, here's the link, here's the website, go to this website and just fill out the application. When you're a family in crisis, your brain is not working right, and filling out the Medicaid paperwork it makes you want to give up. So really, it would be very helpful if you sat with parents, helped them fill out the applications together. So I'm going to spend just a few minutes talking about the 3 things that I wish that my NICU staff would have told me before we were discharged from the hospital, and it's these 3 things. So I wish that I would have been better prepared for how much that experience and beyond was going to impact my confidence as a mother, and just how overprotective I was. I had so many fears for both Ian and also for Isabel, way more than what was warranted. I worried about everything. I worried that they would drown in the swimming pool, that they would drown at the lake, that they would get burned shooting off fireworks at my sister's farm, where we always did the 4th of July holiday there. I worried every single year that Ian would be a bully or be a victim of bullying at school. Looking back, I know that I really overprotected. I really hovered way more than I should have. And this has been the topic of a number of research articles. But in this article by Richard Shaw, it talks about the rigid, intrusive overparenting styles that many parents of preterm infants have. But it also talks about some very brief and cost-effective manualized interventions that can reduce the parent's stress, the trauma and depression, and it can improve maternal well-being and the infant's outcomes. So I was very overprotective, and I wish that I hadn't been. While I don't think that I met the criteria, the official criteria for PTSD, for post-traumatic stress disorder, I have no doubt that I suffered from post-traumatic stress. For me, my symptoms were in the form of nightmares. And in my nightmares, my kids were always, both Ian and Isabel, and sometimes even Alex would make an appearance in my nightmares, where they were just on the brink of death. And during the scene, I was always there. I was always present, but I was negligent. I was a bad mom in my dreams. I wasn't paying attention to them. And once I realized that they were about to die, I would try to save them, and I couldn't. It was horrible. These nightmares happened about twice a month. I would say about every 2 weeks I would have them, and they lasted for 14 years. It wasn't until I finally sought out some counseling that those thoughts were resolved, and it happened very quickly. Amazingly, it happened very quickly, and I've never had another episode since then. But 14 years is too long to suffer from those kinds of thoughts. I would have loved to have had some information about PTS that had been provided to me either upon discharge or during all of the follow-up clinics that we attended. Somewhere along the line, I wish somebody would have talked to me about the struggles that are very normal for NICU parents, what the signs and symptoms were, and what I should do about it. And the last thing, the third thing, is I wish that I had been better prepared for Ian's lifelong impacts. Once I got over that initial shock of his cerebral palsy diagnosis, and I finally understood that his disability wasn't going to be in a wheelchair without the use of all of his extremities, it seemed more manageable to me. At that point, I really believed that his only challenges, now it sounds so naive, but I feel like his only challenges were that he would have just some slight delays and some manageable physical disabilities. I was not prepared. I wasn't expecting the emotional toll that his disability would take on him. So I want to talk on the next couple slides about those other side effects of the preterm or NICU stay that we often call minor morbidities or comorbidities. First off, I don't like this term of minor morbidities because there's nothing minor about anything on this list. But these are sort of the other outcomes that happen from a NICU stay. I kind of call these the side effects of being in the NICU. They're not necessarily disabling, but when you realize that you almost never have just one of these by themselves, that's why they're called comorbidities. Families many times are dealing with more than one. These were some of the ones that Ian was experiencing, and adding that onto the physical disability and onto some of the learning challenges, that's a heavy toll for us, for the family, but it's a really heavy toll for Ian to bear, or for any of our kids to experience. I attended a conference earlier this year, and one of the presentations called Beyond the Bailey was they had interviewed parents of preterm infants, or of NICU kids, graduates, and they asked them, how do minor morbidities impact the family? And these quotes hit me like an arrow through my heart, because I recognized all of them, and I had never really heard it voiced in that way before. But it's important for us to remember that as the NICU graduates graduate and they're in the pediatrician's office and beyond that, that they're still dealing with and working through some of those other comorbidities, and trying to work through those. So you all have an amazing opportunity to help families become as resilient as possible. You have a great opportunity to help families enact their or engage their coping strategies, or at least help them through some of those things. So I want to talk about it in three different buckets. While in the hospital, helping families think about not just the clinical needs of the child, but also thinking about the mental health and the emotional well-being. I know that there's sort of a trend that's happening right now across the country with having professional mental health professionals in the NICU as a staff person. So having a psychologist or psychiatrist on the unit. I can't say enough how much that would have been helpful for us to have had. I applaud those hospitals that are staffing that position in the hospital. The opportunity for a parent to actually go on the unit and talk to a psychologist and talk about some of the fears and the anxieties would be a really great thing. Also having parent and family support programming, so similar to the NICU family support program or other parent-to-parent support groups and support programming. Kudos to those hospitals that are doing a great job. I know there are hundreds of you out there, and so you're really thinking more about just the clinical needs of the baby, but you're also thinking about what are those emotional needs that the family needs also. The second bucket is once the family graduates from the hospital, what happens? It's the now what, right, in the community support. So some communities do a really good job of having parent support groups or group opportunities and kid group opportunities. Some communities really need to work on that. However that works in your community, just think about building that up a little bit more. I've already talked about the Medicaid and waiver programs, but really they need help filling out those documents. Those services to families are so important. So they need help, though they're in crisis. They can't fill out the paperwork. And then finally, there's so much research about the mental health and the emotional well-being of the NICU graduate parent. And there's only just now starting to really think about what's the emotional toll on the child. So I'm working right now with the American Board of Pediatrics Foundation on a pediatrician mental health toolkit, and they're looking at that right now on providing a toolkit for pediatricians who are seeing kids in their office from birth up to 18 years old, and being able to identify mental health or emotional well-being issues or challenges. So more to come on that. And then just really thinking about what the post-traumatic stress is on the child. When I look at that in terms of Ian, I can see it now. I didn't see it early on. So I'm going to end with some successes because I think it's important to do that. Ian turned 26 on Wednesday. Happy birthday, Ian. He's had a lot of successes. I want to just sort of shout out a couple of them. His driver's license was a huge deal. I want you to think about what your life would be like if you didn't have a driver's license. What would it mean to be completely dependent on somebody else or on public transportation? So for him, getting a driver's license was really important, and he worked really hard to get it. He got a bachelor's degree from Pittsburgh State University in English. He's working full-time, he's living independently, and he's paying 99% of his bill. He's paying his bills. So he's had some great successes in spite of being 2 pounds 4 ounces at birth. On the bottom, I just want to recognize the March of Dimes. They've been a huge support to me, and this is our family page, our family team of marchforbabies.org/Millers in Motion. So just wanted to throw that out there. So if anybody had ever told me 26 years ago that when I was an elementary music teacher that I would be a writer, I would be researching, I'd be conducting trainings for NICU and perinatal staff to an international audience, I would never have believed them. But that is the power, really, of the NICU experience. It changes not only lives, but it changes and pushes people off into different areas professionally, stretching them into areas far beyond their comfort zone. So I just want to thank each one of you, not only for spending this hour with me, but also for the work that you do for the families and for the kids that you work with. So please reach out to me for more information about the March of Dimes NICU Institute. If you'd like to bring a family-centered care training or a webinar to your hospital, just let me know and I'd be happy to make that happen. Thank you so much.
Boy, thank you, Laura. That was just an amazing presentation. Thank you for sharing, and I'm sure for those people that are working in the NICUs, that has a lot of impact. And someone in one of the comments right away, I just want to share this with everyone, said, thanks for sharing the real and vulnerable side of parenting, Laura. Amazing presentation. Our NICU Birth Center PICU needs to see this webinar, and I'll make that happen.
Great.
It was really, really great discussion. We want to open it up for questions right now. Kathy Randall is going to help facilitate the questions. If you click on the black band at the bottom of your screen, you'll see a chat area. And if you could put the questions in the chat area, that would be the easiest for us to feed them to Laura.
There's lots of comments about just awesome, seriously the best, thank you. So we're waiting for people to do that.
Here's a question from the Q&A. I've been a social worker in the NICU for 30 years, and we are the mental health professionals for our parents. Did you have a social worker? If so, did that person not address some of your mental health struggles with NICU parenting?
So I'm really glad that you asked that question. We did have a social worker. She did approach us early on. She saw that Kelly and I were in a strong marriage. She saw that we lived in a pretty stable environment, that we were both college educated, that we had a good support system, and that we seemed like we were handling things really well. So she handed me her business card and she said, let me know if you need anything, I'm here for you. That was our one and only experience with our social worker for 6 months in the unit. I would say that since then I've worked in 2 other NICUs, and I know that you know that's changing for sure. That the social workers are really much more in tune with some of those mental health struggles that families are going through. And yet, Kathy, they are stretched so thin. They are working and really focusing mainly on sort of those social dysfunctionalities that have to occur, the SRS kind of challenges, and don't really have time to sit with somebody like me who seemed like I had so many advantages. So so it's sort of a double-edged sword.
Interesting. I like what you said about the bedside nurse sitting with the parent, because I think that who knows where that parent is at that time in that situation, even if they are getting social work and other support. The people that are there day to day are the ones that are really seeing the ups and downs of the parents, even if they seem like they're pulled together and have the education. Here's one more question, just a comment on the growth chart. We find many practices do not use preterm growth charts or do not use the infant's adjusted age, which makes a huge difference on where the point on the chart falls. We suggest using the adjusted age for the first 18 months of life.
Thank you so much. I really appreciate that. I would have, I would have looked at it at that point, but it just made me feel bad. So I'm through. I didn't even realize that there was a different growth chart.
For some reason, the chat area, I can't even open that up. So if people have other questions, perhaps you could go to the Q&A instead. That's where I'm getting these questions so far. Many positive comments, Laura.
Good.
Okay, if we don't have anything else, I'm just going to thank you again for sharing your journey. In order to receive your free CE, you will need to fill out the webinar evaluation in the chat area, or hopefully Kathy Randall can put up. Hold on, I'm going to go back to another question. I work at a VA hospital with PTS screening And PTS screening is a regular screening tool for veterans in our system. When bringing families into the NICU, is PTS screening part of the family intake process?
I can't answer that. That's not my area of expertise. I would say that every hospital there's not really a standardized process for many of the processes in the NICU, and so that's not one of the standardized processes. I know that some hospitals do a screening for PTS, and I know that many of them do the mental health screening for all families. But sometimes hospitals only will set a criteria. So they'll say once a family is in the hospital for like 2 weeks, that's the trigger point of when we actually have our social workers meet with those families. So there's really no standard answer to that.
One other question that I would say the PTSD screening is not standardized, but hospitalized mothers are getting better at standardized screening for postpartum depression in the NICU.
Yeah, and there's a lot of information. It's changing so much with technology and social media. So there's a lot of information that's out there, but that is not where we want our families to be getting their information. We don't want them. We want to, make sure that we're sort of controlling that information that they're getting. So for me, leaving the hospital with nothing in your hands talking about postpartum depression or mental health needs is a travesty, especially when we talk about our families who are in the NICU for a shorter stay, those families who are in the NICU for 2 weeks or under. Some of them are leaving without any information on mental health or emotional well-being, and it's not until they get home with their baby in a very vulnerable situation that their postpartum depression starts to kick in, and then they have nothing from us.
Was there ever counseling made available?
Could you repeat that again?
Sorry. Was there ever any financial counseling made available?
No, not from the hospital. A one side note about how much time do we have to talk about finances? Yeah, it's a huge toll. It's a financial toll for families. We had good insurance. We were really lucky. My husband worked for the government, and we had some really amazing insurance. I know how lucky we were. Those bills would be coming in. I was very meticulous about 3-hole punching, putting them into a folder and sort of keeping a track of how much it was adding up to. We had two folders, one for E and one for Alex. When the number hit $1 million, I stopped collecting those. I started not 3-hole punching. It was overwhelming for me. I started throwing away our bills because I couldn't even think beyond that.
Wow. I work with parents in the NICU, and I offer parent support from former NICU parents. The trend lately has been for parents to decline this support. How can I encourage them to take advantage of this without being pushy? I am a former mom as well.
Yeah, so I love this question, and you are going to have a number of parents who are not at that point where they want to have somebody sit with them. I like the opportunity of just having the opportunities available for them, having activities that are available for families. A lot of our sites will do, a lot of the NICU family support sites will have a calendar of events, and so it goes beyond the CPR training and the safe sleep training, and they're doing other kinds of education and just offering up those opportunities for families to get together. I would say just keep offering them. Bring food, that's always helpful. Maybe have a gift or a giveaway that families can raffle off. That might be an option also, but and then change up your timing also. So do an evening, do an afternoon, do a weekend. You got to really work at trying to reach all the families. Great.
And one last comment. Our healthcare is now in a position for profit. That is that the law, it's a little confusing, that there never seems to be enough professionals or time for the help everyone needs in terms of illness. So I think that was just a comment. And just one more. I like your suggestion of preparing parents for the emotional trauma and PTS at home but I suspect most parents taking a baby home from the NICU would actually find this upsetting. Do you think you would have wanted it at that time?
Yeah, you really have to sort of think about this in two different ways. I believe education is important. I think it's more on our end, on the professional NICU end. I don't see how we can't give families information about what possibly might happen and what they might experience. I think it's really important for them to know. The last thing that we want is a family to get to the NICU or get to home and then start feeling those, those feelings and emotions. That's a vulnerable place for a parent to be. It's a vulnerable place for a baby to be also. They need the information. I would have appreciated it.
Laura, Kathy Randall, can you hear me?
I can.
I thought just some of your scripting around how to open the conversation was probably some of the most profound information I've heard in a long time, and really appreciated all of just the honesty and just really this journey that you shared. And I think it is telling, and the PTSD stuff is so real for so many families. I think the statistics are up to as high as 50%. And so I think to the point is well taken that, do we want to stress families out with information that may not apply? But I think that as healthcare professionals, we oftentimes underestimate how frequent these things are. And PTSD is the extreme, where there are extremely mild, there are much more mild manifestations of this. And I think to some degree, any bit of anxiety and depression is probably normal. And what I've found from families is that it doesn't distress them as much as it makes them feel more normal. Like many families experience this, not all families, but many families experience this. And I think mostly what I've seen is parents feel relieved to know that those feelings are normal.
Kathy, thank you so much. That was like so way more eloquent than how I said it. I couldn't agree more. Thank you.
No, your presentation, and it's being echoed time and time and time again. It's really was one of the best ever.
Oh, thank you. I appreciate that. I'm very humbled that anybody wanted to hear my story and share the time with me. So thank you.
Well, happy Mother's Day on that.
Thank you. Same to you and everyone else out there.
And just to come back to the CEs for a minute, all you have to do is go in the chat area and click on the link. At the end of the evaluation form, you will receive a link to the CE certificate, which you will have to download for your records. If you don't have time to fill out the evaluation right now, or your hospital has blocked your internet access, you will receive an email sometime today or over the weekend with a link to the evaluation as well as a link to the recording. If you're viewing as a group, each one of you must log into the evaluation form to get the CE. And we do hope you'll visit the DandleLION website. This was our 35th free webinar, and all the recordings are up, and the last 3 years are available for CE credit. So again, I echo what Kathy and Laura said. Happy Mother's Day to everyone. Have a great weekend. And Laura, thank you for sharing with us.
You're welcome. Thank you.